He was 71 years old and he had never felt better. He had retired 2 years prior, started walking 5 miles a day, lost 18 pounds, and by every measure he could identify, his life was finally beginning rather than winding down. Then came the stress test. His primary care physician had ordered it as a routine precaution. Nothing specific, no symptoms, just due diligence. The test came back with a finding. His cardiologist referred him for a coronary angiogram. The angiogram showed partial narrowing in one coronary artery, significant looking on the imaging, not causing any symptoms, but there on the screen in black and white. The cardiologist recommended a stent. His wife looked it up online and found that coronary stents were a routine procedure with high success rates. His son told him to do whatever the doctor recommended. He had the stent placed. Within 6 months, he was back in the catheterization laboratory with a complication at the stent site. He spent 3 weeks in cardiac rehabilitation. He lost the fitness he had spent 2 years building. He never returned to the 5-mile walks, and the procedure that was supposed to protect his heart had, according to the research that existed long before his cardiologist ever ordered that stress test, provided him with no measurable benefit over the medication alone that he could have taken instead. The research was there. He was never shown it. What I am going to give you today is not a manifesto against medicine or surgery. I have spent my career in medicine, and I have enormous respect for what surgical intervention does when it is genuinely indicated. What I am going to give you is something more specific and more valuable than general skepticism. The research on 5 specific procedures that are performed routinely in adults over 65 that carry real and measurable procedural risk in the aging body, and that the highest quality clinical trial evidence shows provide either no benefit, uncertain benefit, or benefit so modest relative to the risk that the calculus changes significantly after 65. These are not fringe positions. They are published findings from the New England Journal of Medicine, from JAMA, from The Lancet, from trial registries and systematic reviews that represent the best available evidence in their respective fields. They are findings that many surgeons and interventional cardiologists know exist and that many do not communicate to their patients in the time available before a consent form is signed. I am Dr. Edward. What you are about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. The procedures I am going to describe are sometimes absolutely the right choice, the right patient, the right severity, the right timing. What I am giving you is not a reason to refuse surgery. It is a framework for asking better questions, requesting specific evidence, and understanding what the research actually shows about the procedure being recommended to you before you agree to it. Every person over 65 deserves to walk into that consent conversation armed with this information. Your surgeon has it. Now you will too. Subscribe to this channel right now before we begin, because this video contains the research that your surgeon may not have time to walk you through, the trial names you can look up yourself, and the specific questions that change what happens in a pre-surgical consultation. Subscribe now, it is free, and stay with me for all 5. Before I give you the procedures, let me give you the biological framework that makes age such a critical variable in surgical risk assessment, because the risk calculation is not the same at 45 as it is at 70, and understanding why changes how you evaluate every procedure recommendation you will ever receive. The aging body is physiologically different from the middle-aged body in ways that surgical and procedural risk models have historically underestimated. Cardiac reserve, the heart's capacity to increase output under physiological stress, declines measurably with age, meaning the heart has less capacity to compensate for the hemodynamic demands of surgery and anesthesia. The inflammatory response to surgical trauma is amplified in older adults and resolves more slowly, producing the prolonged recovery, heightened infection susceptibility, and wound healing impairment that surgeons call the postoperative inflammatory cascade. Renal function declines with age in ways that affect drug clearance, fluid balance management, and vulnerability to contrast-induced nephropathy during the imaging procedures that precede and guide many interventions. The blood-brain barrier becomes more permeable with age, making older adults significantly more vulnerable to postoperative cognitive dysfunction, a condition in which measurable cognitive decline follows major surgery and that in a meaningful proportion of patients does not fully recover. Research published in Anesthesiology has found that postoperative cognitive dysfunction occurs in approximately 25 to 40% of patients over 65 after major surgery, and that in 10 to 12% the decline persists beyond 3 months, and perhaps most importantly, the functional reserve across multiple organ systems that allows a younger patient to tolerate procedural stress and bounce back quickly is simply thinner in the over 65 population. A complication that a 45-year-old experiences and recovers from completely may permanently reduce functional capacity in a 70-year-old. A week of immobility in hospital following a procedural complication at 72 produces muscle loss, deconditioning, and fall risk that takes months to recover and in some patients is never fully reversed. This is not pessimism about aging. It is the biological reality that should adjust the benefit threshold at which a procedure becomes worth recommending. The risk floor is higher. The functional cost of a complication is steeper. The potential remaining benefit horizon is shorter. Every one of these factors requires that the evidence for the procedure being offered be genuinely strong before it is accepted. The first procedure is coronary artery stenting, percutaneous coronary intervention, or PCI, for stable coronary artery disease without acute symptoms. I want to be very precise about the qualifier because it is essential. I am not describing stenting during a heart attack or an unstable angina, where the evidence for immediate intervention is overwhelming and the recommendation is unambiguous. I am describing the scenario I opened this video with: the discovery of coronary artery narrowing on imaging in a patient who has stable or no symptoms, followed by a recommendation for stent placement to prevent future events. The landmark trial on this question is ORBITA, the objective randomized blinded investigations with optimal medical therapy of angioplasty in stable angina, published in The Lancet in 2017. ORBITA was the first properly blinded randomized controlled trial of PCI versus sham procedure for stable angina. Patients with significant single-vessel coronary narrowing and documented stable symptoms were randomized to either receive a real stent or undergo a sham procedure in which the catheter was inserted. The lab was run identically, but no stent was placed. Neither the patient nor the outcome assessors knew which intervention had occurred. The results were striking. PCI produced no significant improvement in exercise capacity, no improvement in angina frequency, and no improvement in quality of life compared to the sham procedure at 6 weeks. A larger subsequent trial, Ischemia, published in the New England Journal of Medicine in 2020, randomized over 5,000 patients with stable ischemic heart disease to either invasive management, including stenting, or optimal medical therapy alone. After a median follow-up of 3.2 years, there was no significant difference in the combined endpoint of cardiovascular death, heart attack, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest between the two groups. What does this mean practically for an adult over 65 who is told they have coronary artery narrowing and a stent is recommended? It means the first question to ask is, do I have acute symptoms? Chest pain at rest, unstable or worsening symptoms, or evidence of active severe ischemia on testing? If the answer is no, the evidence supports a trial of optimal medical therapy as equivalent in outcomes to stenting without the procedural risk. The risks of PCI are real and age-related. Contrast nephropathy is more common and more severe in older adults. Access site complications increase with arterial stiffness. Stent thrombosis requires prolonged dual antiplatelet therapy that significantly increases bleeding risk in a population already on multiple medications. And the cognitive effects of catheterization laboratory sedation compound the post-operative cognitive dysfunction risk I described earlier. The conversation is not about refusing cardiology care. It is about asking, what is the randomized trial evidence for this intervention in a patient with my symptom profile? And have we genuinely maximized medical therapy before reaching for a procedure? The second procedure is spinal fusion for nonspecific or degenerative lumbar back pain, surgery in which 2 or more lumbar vertebrae are permanently joined with metal hardware to eliminate motion at that segment. Spinal fusion is among the most commonly performed surgical procedures in the United States, with over 400,000 performed annually, and its use has increased by over 200% in the over 65 population over the last 2 decades, despite a body of clinical trial evidence showing that outcomes for the majority of patients are not significantly better than non-surgical treatment. The SPORT trial, Spine Patient Outcomes Research Trial, examined surgical versus non-surgical management of the 3 most common conditions driving fusion recommendations: intervertebral disc herniation, spinal stenosis, and degenerative spondylolisthesis. For disc herniation and spinal stenosis, which together account for the majority of fusion referrals, the trial found that while surgical patients had faster initial improvement, the differences in pain, function, and disability between surgical and non-surgical groups were not statistically significant at 4-year follow-up. Patients who chose surgery did better initially. Patients who persisted with non-surgical management caught up over time. The most clinically significant finding for seniors considering spinal fusion is the adjacent segment disease rate, the development of accelerated degeneration and new symptoms at the vertebral levels immediately above and below the fusion site, which occurs at a documented rate of 2 to 3% per year. Over a 10-year period, an adult who undergoes lumbar fusion at 65 has a 20 to 30% probability of developing adjacent segment disease requiring additional surgery. This is not a rare complication. It is a structural consequence of eliminating motion at one segment and transferring its mechanical demands to neighboring segments that are already aging. The hardware failure rate in older adults, where bone density affects the anchoring of pedicle screws, the surgical site infection rate in a population with higher rates of diabetes and impaired wound healing, and the postoperative cognitive dysfunction risk from several hours of general anesthesia all add to the risk ledger. The question to ask before agreeing to spinal fusion is not whether the surgery can reduce pain in the short term. It can, and sometimes significantly. The question is whether a minimum 6 to 12-month trial of structured physical therapy, targeted interventional pain procedures, and behavioral pain management has been genuinely completed and documented as having failed before the surgical option is offered. In many cases, it has not. The third procedure is carotid endarterectomy, surgical removal of plaque from the carotid artery for asymptomatic carotid stenosis discovered incidentally on imaging. This is among the most emotionally compelling recommendations a senior can receive, because the word carotid and the word stenosis together sound like imminent stroke. Understanding what the evidence actually shows is essential before agreeing to a procedure that carries its own stroke risk. Carotid endarterectomy for symptomatic stenosis, patients who have had a transient ischemic attack or stroke attributable to the affected artery, has strong, consistent evidence supporting it when performed promptly. Asymptomatic stenosis is a fundamentally different clinical scenario. The trials that historically supported endarterectomy for asymptomatic stenosis, ACAS and ACST from the 1990s, found a modest absolute benefit of approximately 1% per year reduction in stroke risk. But those trials were conducted before modern optimal medical therapy was standard. High-intensity statins, dual antiplatelet agents, aggressive blood pressure targets, and smoking cessation programs have collectively transformed the natural history of carotid plaque. Contemporary observational data from patients on modern medical therapy suggests that the annual stroke risk from asymptomatic carotid stenosis, even at greater than 70% narrowing, may be as low as 0.5 to 1% per year in well-managed patients. The real-world procedural stroke and death rate from carotid endarterectomy in community hospitals, not high-volume trial centers, averages 2 to 3% across published series, when the annual stroke risk from the stenosis on optimal medical therapy is 0.5 to 1%, and the procedural risk is 2 to 3%. The procedure must be performed perfectly and without complication for several years simply to break even on stroke prevention. The ongoing CREST-2 trial is comparing endarterectomy and carotid artery stenting against intensive medical therapy in asymptomatic patients with modern treatment. Until those results are published, the question for every senior facing this recommendation is, what is my current medical therapy regimen? Am I on high-intensity statin therapy and antiplatelet therapy What is the documented procedural complication rate at this specific institution, and have we measured my annual stroke risk on current treatment before comparing it to the procedural risk? Subscribe right now if you are going to share this video with someone preparing for a surgical consultation. Subscribe before you share so the follow-up content reaches you directly. Then stay for the fourth and fifth procedures. The fourth is the one most likely to affect the men watching this, and the fifth is the one I consider most universally important for anyone over 65 facing any major medical intervention. The fourth procedure is aggressive treatment of low-risk prostate cancer, specifically radical prostatectomy or high-dose radiotherapy for PSA screen-detected prostate cancer, graded as Gleason 6 or low-risk Gleason 7 on biopsy. Prostate cancer is unique among common cancers in that it encompasses a spectrum of biological behavior, from extremely indolent tumors that will never produce symptoms or cause death in the patient's lifetime, to aggressive cancers requiring urgent intervention. The challenge is that PSA screening and initial biopsy cannot reliably distinguish which tumor will remain indolent and which will progress, a limitation that for decades drove over-treatment of low-risk disease on a massive scale. The PROTECT trial, published in the New England Journal of Medicine, randomized over 1,600 men with localized prostate cancer to active monitoring, radical prostatectomy, or radiotherapy. After 10 years of follow-up, there was no significant difference in prostate cancer-specific mortality among the three groups. Fewer than 3% of men in any group had died from prostate cancer. The men who underwent surgery had significantly higher rates of urinary incontinence and erectile dysfunction than those in active monitoring. At 10 years, 17% of men in the surgery group reported urinary leakage daily, compared to 4% in the monitoring group. The men who received radiotherapy had significantly higher rates of bowel symptoms and rectal dysfunction. The men in active monitoring had higher rates of disease progression on imaging and biopsy, but their survival was equivalent. The conclusion is not that treatment is useless for all prostate cancer. It is that for low-risk localized disease, the functional harms of treatment are real, lasting, and measurable, while the survival benefit over monitoring is not demonstrable at 10 years. For a man of 72 or 75 discovered to have a Gleason 6 prostate cancer on a PSA-triggered biopsy, the critical question is not whether the cancer exists, but whether that specific cancer will cause death or significant illness in his remaining lifetime, or whether it will be outpaced by the competing causes of mortality that affect all older adults. Active surveillance, regular PSA monitoring, repeat biopsy at intervals, and multiparametric MRI imaging to assess tumor characteristics allows the tumor to be observed and treatment to be offered specifically if evidence of progression emerges, without committing the patient to the irreversible functional consequences of treatment for a cancer that may never have become clinically relevant. A man over 70 with a Gleason 6 cancer, a PSA below 10, a favorable MRI, and a life expectancy under 15 years is a candidate for active surveillance under any major oncological guideline. The question to ask your urologist: what is my specific Gleason grade? What does my multiparametric MRI show? What is my PSA velocity? And what would my 10-year survival probability be on active surveillance compared to immediate treatment given my age and current health? The fifth procedure, and this is the one I want every senior and every senior's family to carry with them into any major medical decision, is major elective surgery or aggressive cancer treatment undertaken without formal frailty assessment. This is not a single specific procedure. It is the absence of an evaluation that should precede every major intervention in adults over 65, and that is standard practice in far too few hospitals. Frailty is a validated clinical syndrome of reduced physiological reserve in which the body's capacity to respond to and recover from stressors is substantially diminished. It is measured by validated tools, including the Clinical Frailty Scale, the Fried Frailty Phenotype, and the Modified Frailty Index, each of which captures different dimensions of the same underlying vulnerability: unintentional weight loss, exhaustion, low grip strength, slow walking speed, low physical activity, and accumulation of deficits across multiple health domains. Frailty is not synonymous with age. There are robust 80-year-olds who score as non-frail and vulnerable 67-year-olds who score as moderately to severely frail. The The distinction matters more for surgical and oncological outcomes than any other single preoperative variable. Research published in JAMA Surgery found that frailty was a stronger independent predictor of 30-day surgical mortality, major postoperative complications, prolonged hospital stay, and discharge to nursing facility than age, ASA class, comorbidity burden, or surgical complexity score. A frail patient undergoing elective colectomy at 68 has a statistically higher risk profile than a non-frail patient undergoing the same surgery at 78. Yet frailty assessment is not a routine component of standard preoperative evaluation in most institutions. Patients are evaluated for cardiac reserve, for pulmonary function, for renal status. They are rarely scored on the clinical frailty scale or the Fried phenotype, and the surgical plan is rarely modified based on frailty status. In oncology, the evidence is equally compelling and equally underutilized. The International Society of Geriatric Oncology and the American Society of Clinical Oncology both recommend comprehensive geriatric assessment, which includes frailty evaluation, before treating older adults with cancer. Research published in the Journal of Clinical Oncology found that comprehensive geriatric assessment identified clinically significant vulnerabilities in over 50% of older cancer patients that oncologists had not detected in standard clinical evaluation, and that incorporating geriatric assessment findings changed the treatment recommendation in approximately 30% of cases. A frail older adult receiving standard dose chemotherapy may experience toxicity, hospitalization, and functional decline that permanently reduces their quality of life. A dose-modified regimen calibrated to their physiological capacity may achieve equivalent disease control with substantially less harm. The question to ask before any major surgery or cancer treatment if you are over 65 is, has my frailty status been formally measured, and is the proposed treatment calibrated to my physiological age and functional reserve, rather than simply to my calendar age? The 5 questions I want you to memorize before any pre-surgical consultation over the age of 65. First, what is the highest quality randomized trial evidence for this specific procedure in a patient with my specific presentation? Not observational data, not the surgeon's personal series, but the published randomized controlled trials. Second, what is the documented procedural complication rate at this specific institution for this specific procedure, not the national benchmark? Third, what is the evidence-based non-surgical alternative? And has it been genuinely tried and failed with documentation? Fourth, how will this procedure affect my functional status, independence, and quality of life, not just my imaging findings? Fifth, has my frailty status been formally assessed, and has the risk calculation been adjusted for my physiological rather than my chronological age? Now, before the action plan, this is the moment to share this video. There is someone in your life who has a surgical consultation scheduled and who is planning to agree because the doctor recommended it and because questioning a surgeon feels presumptuous. Share this with them now, before their appointment, not after, so they walk in with these 5 questions rather than a blank signature line. The research I described is real, it is published, and it belongs to every patient. Share it before we go to the action plan, then come back. Here is what to do in the next 48 hours based on everything you just learned. If you have a procedure currently recommended, write down the name of the procedure and the indication your physician gave. Then, before your next appointment, look up the trial names I mentioned for the relevant procedure and bring them by name. Ask your physician or surgeon, can you walk me through what the randomized controlled trial evidence shows for this specific procedure in someone with my symptoms and my age? Write down their answer. If they cannot identify a randomized trial, that is important clinical information. Request the institutional complication rate. This is not an aggressive or insulting request. Ask, what is the 30-day major complication rate at this hospital for this procedure in patients in my age group? Every accredited surgical department tracks this. You are entitled to it before consenting. Ask about the non-surgical alternative with specificity. If coronary stenting has been recommended, ask whether high-intensity statin therapy, beta blockade, and antiplatelet therapy have been optimized. If spinal fusion has been recommended, ask for documentation that structured physical therapy and interventional procedures have been attempted for a minimum of 6 months. If treatment for screen-detected prostate cancer has been recommended, ask specifically about active surveillance eligibility. If you are over 70 and facing any major surgery or cancer treatment, ask your surgical or oncological team for a formal frailty assessment before the procedure. Ask specifically for the clinical frailty scale or the modified frailty index. If this request is unfamiliar to your team, ask for a referral to a preoperative geriatric consultation. This request is medically supported, increasingly standard in academic centers, and changes outcomes. You now know that the question is never simply whether to trust your physician. It is whether the research they are relying on applies to your specific presentation, your specific age, and your specific physiological reserve. The surgeon who cannot answer the questions I gave you is not necessarily a poor surgeon. They may be an excellent technical operator who has simply never been asked these questions in a pre-consent conversation. These 5 questions create the opportunity for that conversation. Use them. Subscribe to this channel if you have not already. My next video covers the 5 medications that research consistently shows are overprescribed in adults over 65, including one that is in virtually every senior's medicine cabinet and that carries a risk profile at this age that most daily users have never been told about. Subscribe so it comes directly to you. I am Dr. Edward. You are not just a patient. You are a participant in a medical decision. Now you know how to participate. I will see you in the next one.